we should get this done. There's some really practical things to get started. Cost effectiveness in your processes and your implants is a great place to start. You have to make sure you have follow-up resources in place. Patients who need therapy have to be able to get therapy. People who have complications have to have a way to get help with their complication, because that's the nature of surgery. They do come up. And then you need to have an equitable and a functional system for triage in both your clinic and in terms of who gets to go to the operating room. Again, these are very practical things. And the last practical thing you have to look at is quality assurance, and making sure that we're meeting our standards. Then with ethics, anytime there's an ethics discussion, you have to get a little bit theoretical. So we have to think about making sure that we don't do things abroad that we wouldn't do at home. We have to make sure that we're not becoming a burden to the local infrastructure and to the local healthcare workers. This is especially important in conflict and in disaster response, which I'm not talking as much about today, but things like linguistics and personal fitness can become really important. We have to always remember, as we think through these things, that we're operating as a part of a much bigger environment. There's things like governmental regulations, government infrastructure, and public health infrastructure that we can affect, and we have to operate within those confines. And then again, getting a little theoretical here, we have to make sure we're doing surgery for someone. We have to be doing it for the patient and not to the patient. And we have to make sure that our first priority is sustainability. And we have to always look at our motives. Are we doing this to feed our own ego? Or, the famous surgeon's God complex, are we feeding into that? Or are we really doing this to help people and not just for a PR opportunity? So as we think about this, I think there's some good models out there for how we can do this work. The IGOT, based out of San Francisco, has a multi-pronged approach. They're involved in surgical education, both international and domestic medical students, residents, and faculty. They do a lot of global knowledge exchange, things like soft tissue, flap labs, implant training, both locally as well as video conferenced out so that anyone internationally can be a part of it. They also have some really great research infrastructure and initiatives with the World Health Organization, which gives them a really wide reach in terms of helping to understand exactly what the burden is and how we can affect it. And because of their involvement with some of these larger and international worldwide organizations, they have positioned themselves as leaders and advocates for some of these people and getting them what they need. And again, because of their wide reaches, they're able to work with a group called the Surgical Implant Generation Network, or SIGN. It's well known among the global health ortho community because they develop implants that can be used to treat fractures and other issues with extremely low resource availability. And they find ways to do this. And the IGOT helps design these, they help study the biomechanics, and they help looking at cases of failure and understanding why they happen and to make improvements. So now we'll talk a little bit about what we're involved in. The Restore Central America group was founded and directed by one of our own, Dr. Joe Shu, and he does annual trips every year to help with training, to help with fundraising, to help educate the fellows and residents down in Honduras, as well as to bring our own residents here from CMC to be a part of this. And there's a lot of two-way exchange of training. Some of those low-tech solutions come out of these types of trips and these types of relationships, and he does a lot of flap and deformity training for them, as well as educating some international emergency medicine residents. And Dr. Brian Brighton, as you can see in the photo here, one of our great pediatric attendings, is one of the co-directors and very involved with this as well. Moving on to the Op Walk, the Operation Walk Carolinas was founded by Dr. Brian Springer, one of our hip and knee attendings. Had a recent trip to Panama last year. They brought around 50 total staff, including the surgeons, and they performed 60 total hip and knee arthroplasties in 3 days in the operating room, which obviously is amazing, amazing volume. They'd previously taken trips to Cuba and Honduras. Unfortunately, their trip this year was canceled. For the spine and neurosurgery side, Dr. Chapman, our very own Dr. Chapman, took a trip last year, saw over 200 clinic visits, and did close to 30 surgeries. And again, he was joined by about 20 staff. And our CNSA partners, neurosurgical partners, have been extensively involved in Africa and Asia in the past with service trips as well. The Ortho Carolina Foundation hosts an International Fellows Program. This was organized by Dr. Tom Faring. And it's a great program. Their international fellows are selected and brought in for 4 weeks of training. They get to pick their own subspecialty. They get to learn from our attendings, and they also get to teach fellows and residents. We've previously hosted 18 fellows from all across the world, as you can see here, Asia, Africa, Central and South America. So how can we do more as we look at this, as we talk through it? What are some things we can do? And doing more at home is always the first step. We need to examine our own processes and see how we can improve. And the first step of that is just awareness and advocacy. Again, the communicable diseases get on the news a lot, and there's huge amounts of money thrown around by international foundations, and that's just not happening quite as much with the musculoskeletal pathology, so we have to be advocates for our patients. Research is another thing you get involved in without leaving your couch these days, as well as fundraising. Even if you can't be a part of the service trip for whatever reason, you can always help fundraise with some of these trips. And then there's infinite ways to build sustainability. Just yesterday, one of the operating room nurses here at Mercy told me that some of the sterile drapes that had never been used, never been touched throughout the hip case, when she went to throw them away, they weighed about 10 pounds. So that one case, we wasted about 10 pounds of sterile drapes. So we have to really examine our processes, make sure that we have our pick sheets down to minimize our waste. DME recycling can be difficult because storage and shipment of DME is really costly. And so it's difficult to have recycled DME be a part of these service efforts, but we can certainly recycle our own DME at home. And then the last thing, another great way to build sustainability, is X-Fix pin reprocessing. So these are highly costly, and single use of these is extremely wasteful. They can be reprocessed, and they have similar biomechanical strength, and they've been determined in randomized controlled trials to be safe for patients. And I think, in my opinion, this would be a great opportunity for a sustainability effort here at our hospitals, or for charitable donation. Two of our great orthopedic faculty are involved with the Restore group, and in my opinion, that would be a great place for these to go. So again, doing more, looking internationally, building more opportunities for mentorship, for partnership, open lines of communication, exchanging knowledge in both directions, and doing two-way exchange in terms of visits and travel as well. And then again, I think some of these morbidity and mortality conferences, it's a way to check ourselves to make sure that we have quality assurance, and to make sure that we're advocating for our patients and making sure that things are done the right way. And as a kind of last final plug, a question I would leave everyone with is, would this benefit from some formal infrastructure here? We have all these great different ventures, and we have some attendings doing some great work, but would it help us to organize it, to have prongs for education, to get residents involved, to get M&M conferences up and going, to build this knowledge exchange that we talked about, to do some research? You know, the sign implants would really benefit from a set for hemiarthroplasty, and we have some of the best hip and knee surgeons in the world here, so that's a huge opportunity, in my opinion. Also, if we could get involved in some research, we would much be able to better measure our global health impact. We have all these efforts going on, and we would really be able to understand a little bit better what exactly we're doing and how we're helping people. We'll continue to have this great humanitarian work and this volunteerism. Likely will continue to be a blend of some small and large footprint type of ventures. And then the final thing is, we didn't talk about it much today, but a part of global health is disaster response. And so making sure that we at the Atrium Musculoskeletal Health Institute are ready for the next natural disaster, to be a part of it, and to make sure we can be there to help. So in summary here, again, a huge unmet need for MSK health globally. When we do this work, ethics and sustainability always have to be at the forefront of our mind. We have to make sure that we minimize displacement of local workers to minimize the void that inevitably builds when we leave. And we have to first do no harm. We have to make sure that we're doing this work for the right reasons and for the patients, and not for ourselves. Again, we're involved in a lot of different great work with OpWalk, Restore, our international fellows, but we can continue to work on some sustainability efforts here at home, education efforts here at home, and then build new partnerships moving forward. So with that, I'll leave you with my references. And for anybody who's involved, this is a great TED Talk that Dr. Springer shared with me. It's called, "I Would Rather Have HIV Than a Broken Leg." And it's a direct quote from one of Dr. O'Brien's patients. And it talks about some of this unmet need in musculoskeletal health globally. And then a great article out of Canada from McGill University about how global health can mimic colonialism, and how we need to, again, be highly aware of some of the ethics behind this. I have several people I need to thank, and I apologize to anyone who does this work, who I didn't include. I did my best to be inclusive. So thank you, everyone, and I'll open the floor to questions now.
That's fantastic. Thanks, Matt, for sharing that with us. If everybody could turn their, Matt, if you'd stop sharing your screen and have everybody turn their cameras on so we can see each other this morning. So, I think that you made some excellent teaching points there. After the Haitian earthquake, Dr. Bossi had been extremely involved with the Navy ship, and actually went down there for a few weeks. I went down for about 2 weeks to Haiti, and before I went, Dr. Hanley was talking to me, and in his quasi-cynical, comical way said, most people who do this go there to make themselves feel good about themselves and eat the other people's food. And I think you sort of alluded to that a little bit. And I think that is a danger. You have to really, look at the system you're going to, and your breakdown of the different footprints and the sustainability models are really important. And I think that probably the best way that we can really have a true global impact and a sustainable global impact is through the education piece. And I think that's, one of the reasons why Dr. Shu's program in Honduras has been so successful. I mean, they have created a true fellowship there. I mean, if you want to talk about, passing the baton and doing things, I mean, Dr. Shu will tell you himself, most of the time he goes down there now, he barely operates. He's watching everybody else operate. I think from we've discussed this for a long time here. You talked about leadership and infrastructure. The biggest barriers that we face in truly developing a robust international program are a couple things. Proper supervision. So, we don't want to go down there and have a, PGY2 just in a room by themselves all day doing things. That's also called human experimentation. And when I was in Haiti, I saw that. There was actually, there was one of the hospitals out near the airport where people who had a little bit of medical training, like medical student level type training in different countries, just showed up and said, "Oh, I'm a doctor, I'm here to help." And and they actually hurt people. So I think that proper supervision of our residents is going to be really important. Funding is a big deal. You mentioned that. I know Operation Walk does a great job fundraising. Dr. Shu as well. We've had that issue with just our residents trying to find a proper location for them to go where we have funding for them. And then beyond that, very related though is safety. And you have many of these places are not safe places. I mean, when I was in Haiti, we went in a convoy of vans, took a different route every day, had hourly updates on hot zones around town where we couldn't go. So I think that that's definitely a concern. There is a lot of planning that has to go into place for all of these efforts. I would love to hear from some of our faculty and/or residents who have had these opportunities. I see Dr. Brighton on. I'm sure Dr. Shu's there. I don't know if Dr. Springer's around. I don't see his face on my first screen here, but would love to hear from everybody. It's it is something that I think in all of our hearts we'd love to do more of, but finding the right balance of service, education, time, safety, all those things is really difficult. Comments?
Yeah, it's Brian Brighton. I would just say I was very fortunate that, Joe had this program going on down in Honduras, and they were looking to maybe expand it to the pediatric world and really in the deformity. And as like you said, there's been a lot of really just educational exchange that has gone on so that this program can operate while we're not there. We're taking down some equipment, but we have a very small footprint when we're there. But what we're able to do is just allow the surgeons down there to access a couple more ORs and run, the rooms and get some more work done during that week. In preparation for this, as Dr. Shu approached me about this, one of the things that I did do is the AOS disaster course. And I think if they still have that up and running, I think that's a a worthwhile thing to attend if you're interested in it. It's, you know, a couple day of lectures and then a day of labs. So it's about usually a day and a half, 2 days, but really worthwhile, just going over some flaps and other things, and putting on an X-Fix with a hand drill, and you know, things that, those were techniques that we then, you know, ended up using in Honduras. I think the one thing Matt said is that don't do anything down there that you wouldn't do at home. On the other flip side of that is there are things that how you would treat something at home that you can't treat down there, whether it's a certain technology for limb deformity or use of resource use in terms of implants or X-ray intense procedures or anything like that, just because they're not set up to do that. And so, you know, understanding what you're set up to do down there and what you can do, and how you would treat that differently at home versus, you know, in a sort of a less resource intense environment. I think those are some things to just consider, and it has been a great learning opportunity for me. I've learned as much as I've probably given to them. So,
Josh, this is Brian Springer. Sorry I don't have my camera on. I'm out of town, but Matt, that was a great job summarizing, you know, a huge effort in a very short period of time. And I'd encourage everybody to watch that TED Talk from Ed O'Brien. It was really one of the big motivating factors for myself and for our team. I think the other thing, and you alluded to it a little bit, is you know, the whole issue of displacing the local healthcare team is a really sensitive issue, and you know, we've been fortunate enough to go to several different locations, and in some areas it's more sensitive than others. And the whole, you know, this whole philosophy of here we are swooping in, doing 60 joints in the 5 days we're there, and then swooping out, a lot of times does not resonate very well with the local healthcare providers. So, you know, it is about education. You know, we started doing follow-up clinics for all of our patients where I take a small team and we go back down, you know, 3 months later to check on all of our patients. There's another team that goes 6 months later that sees some of our follow-ups, and then we do vice versa. But understanding that there's tremendous cultural differences in how medicine is practiced in different areas, you know, of the world. I distinctly remember on a pre-trip to Cuba, trying to get a form signed to be able to bring pain medicines into the country for our patients that we were going to be doing joint replacements on. And this was our first trip on our own, and trying to get the paper signed by the Minister of the Health, and virtually almost being thrown out of the building for trying to bring narcotics in. And his response was, "We don't want them, and our patients don't need them." Right. And that's a totally different cultural norm than what we think about when we take care of our joint replacements here. And, you know, also just to echo the point, this is about education. You know, Tom's group does a great job of bringing people in. We've had the fortunate opportunity to bring, you know, a few of the residents and some of the local surgeons here. You know, but it ends up being a matter of resources. You know, when we go down there and do, for example, joint replacements, you know, we can teach them and things along those lines. But the bottom line is then we leave and they don't even have implants to be able to do the cases. So we need to try and start to think bigger and globally, and how not only can we teach them, but also be able to provide them the resources for what they need to do to be able to, you know, expand their own footprint.
I'll make one comment, and I think a couple of guys have hit on it, is trying to figure out how to make something sustainable, so that when you leave, you know, you've left a legacy, you've helped them carry on your specific work. I had some health problems, so I decided to bring the residents and fellows and other doctors to Charlotte and to train them. But we're trying to build sustainability in any of these programs. So I think that's a key thing whenever you're thinking about getting involved.
Joe, your comment? There you go.
Yeah, on the sustainability side, well, actually, a disclosure, I'll call out the Spa Dameron and Tenny, who actually pay for the residents to go when they go with me. So that is actually a disclosure. They make donations annually for that. One of the things actually had a big impact on me was Scott Nelson. He's a guy that goes and has spent a lot of time in Dominican and Haiti. And he said, and as I was building this, you know, almost 10 years ago now, he said, you need to do a suitcase trip. And I was like, well, what's a suitcase trip? And he goes, you can only bring and use what you bring in a suitcase. And that's really was very educational. The first few years that I did that, it was a real educational experience, and to really use the tools that they use, to use their anesthesia team, to use their techs, to use their nurses, and that really helped with a bridge to the sustainability, was to not bring the entire surgical team and actually do it with the locals as well. And so I think that was one of the steps that was probably the most critical step, and I learned it from someone who's been doing it, and he's a multi-generation humanitarian surgeon. His father and grandfather both did the same.
Thanks, Joe. You know, on this educational topic, I will tell you that we're trying to do a little bit of that just via our grand rounds. So I think some people noticed that we made our a link specific to today's talk and shared it to allow outside folks to listen. And one of the impetus for that was Bobby Erden, who recently retired from Ortho Carolina, foot and ankle surgeon. He's been spending a lot of his time trying to do some volunteer work and some overseas work. He's developed a relationship and has spent a lot of time in Tanzania working with a residency program there. So he had inquired about whether or not we could supply this Zoom link to the residency there in Tanzania. So that's actually one of the reasons that we've developed a more public facing Zoom link for our grand round presentations.
Cody to room 7, please. Cody to room 7.
Try and get that done. So I think that it's nice to hear, you know, Matt's summary of all these things, and I think for a lot of folks within our own MSKI to just see the stories of the folks here who are doing these things and reaching out across the world is really great to see. So